It says live.
Yes. Hi, everyone. Welcome back. Today is Tuesday, January 6th. It's 1:00, and this is the first meeting of House Healthcare of this session. So welcome back, everyone. I wanted to just spend a few minutes to, first of all, introduce a couple new people. So we have obviously Representative Portis resigned, and we have her replacement. So why don't you go ahead and introduce yourself to everyone in the committee?
Hello, committee. Delighted to be on this committee. Rep. Cordes was someone I admired and liked very much. I just heard from her. She just texted me and says hello to everybody. So this committee is doing really important, essential work, and I'm just really pleased to be part of that. I live in Lincoln. I represent 4 towns, and I'm ready to get going.
Right. What's your background, Carol?
I'm a lawyer. I opened up my law practice in 1988 in Bristol when I started having a family. And I've been doing that all that time since. I was briefly working with Legislative Council for 1 session. And before that, I worked for the Supreme Court. I love the arts and music as well. So I have a very strong interest in those areas. And I play piano. And yeah, that's about it.
Well, we are thrilled to have you.
Yes, we are.
Happy to have you. And if anyone was paying attention today on the floor, there was a game of musical chairs. And if anyone was taking note, there was 1 empty chair left at the end of all the changes that happened. And while technically the speaker has not introduced our other newest member to take the empty chair, I've asked that Val Taylor come in and introduce herself and spend a little time with us.
I'm Val Taylor. I was appointed in Jim Harrison's position, so District 11. I'm a Vermonter. I'm self-employed since I was 12. I'm a house painter. And when we started our family, I was assisting my husband in his business. He's an arborist.
An arborist.
An arborist.
I know. Do you ever paint the trees?
I never painted a tree. Thank you for having me. I'm excited to meet everyone.
Really excited to have you. Really excited to
Welcome.
have you. And I actually asked our stellar JFO, Nolan Langwell, over the next ensuing days, weeks, I'll have Nolan sit with both of you, kind of give you some healthcare 101, because you're going to be jumping into some things really quickly that are going to go right over your head, and that's okay. I'm not worried about it, so please don't be worried about it. Well, first of all, everybody have a good off session.
Yeah.
What's the definition of good?
Yeah. What was the most exciting thing you did this off session that you want to share that the whole public is gonna?
You want me to start?
Make Brett? Yeah.
There's a lot of things that were exciting, but I would say the most exciting thing that I'm ready to share publicly right at this moment is we took my friend who was very sick and who we thought was going to die, but he's not going to die anytime soon that we're aware of, hopefully. But when we thought it was going to happen, we took him to do this lifelong dream of visiting Paisley Park, which is Prince's music studio. And so we got to go to Minneapolis, which is a city I'd never been to. So I studied the architecture there as part of my opioid policy fellowship. And then we went to Paisley Park. That was really exciting.
Mm-hmm.
And then Prince has appeared in the pop culture in ways that were even more exciting recently, for those who might know what I'm referring to without spoiling it. So that was a real treat. Next.
I'm trying to think of the movie now.
What, Purple Rain?
Yeah. What's the movie? I can't think.
Oh, what show?
Yeah.
Well, you're gonna spoil it. if you say
Okay,
it.
well,
You're gonna
okay.
spoil it if
I'm
you
sorry,
say it.
I'm sorry.
Prince played a pivotal moment in the finale of a
Great
cult
movie.
show, yes.
Hope so, you're
Yes.
right.
Right, wait, hold on one second. Since we have 20 minutes to kill,
Okay,
everybody all day today has been asking me what my legislative priorities are. And frankly, what my priorities are not nearly as important as what our priorities are. So one thing,
Okay.
list one thing, just something that you want to work on this year.
so we're rewinding. So I'm gonna, okay, so my name's Brian, you know, when we say our name and our district too. So I'm Brian
Sure.
Pena from Burlington, Chittenden 15, which is the old North End and most of the East District. I already shared my highlight of the day of the year, which is visiting Paisley Park in Minneapolis. And I'm an Aquarius. I like sunsets and gardening but my priority, that's what it is. One of my priorities that's relevant to this committee is artificial intelligence in the healthcare sector. And I'll be sending all of you a bill to look at and consider co-sponsoring by the end of the day.
He's way ahead of us in all of this, but we're old and we're gonna learn, right? Wendy Critchlow from Colchester, that would be Chittenden 19. What did I do that was fun? I did nothing that was fun. I had 2 weddings. Yeah, and I have a new baby, but that didn't come until after, but, yes. I had to work. And I work for Vermont Health Connect, and I just would like to say.
Thank you for your work.
Thank you.
Yeah.
It's good. I don't know how we can do this. I want to say universal health care. That would be my goal. Because I don't see any way out of it. I'm sorry, I don't want to sound like a defeatist, but I'm watching what's going on at the state level, and people are dropping left and right now. They're just don't even want insurance, and it's very sad.
Mhm.
That's it. Okay, I didn't mean, something, I do have a new grandbaby that was just.
That's
on
what
Christmas
Yeah, I didn't mean to
Day.
out you, but-
Absolutely beautiful.
No.
A Christmas present.
Yes, I'm going down Saturday to go see her.
I think I'll skip over Val because you've already introduced yourself. And I don't know if you have any legislative priorities in healthcare since you,
I'm gonna get my feet wet
that's good.
and ask me again in a month or so.
Okay, that's great.
Alan DeMar, I represent Montgomery Nemusburg, and I only have one priority. Healthcare affordability.
What?
Healthcare affordability. Healthcare affordability.
Affordability, thank you. That's what I did.
That's my only priority.
Anything fun, Sean?
Oh, did I do anything? I'm always having fun.
You always.
Everything is fun.
Every
Everything.
day's fun.
What was your fun thing you did this summer?
One highlight.
Well, I got a granddaughter that's 18 years old that is, had her pilot license at 17. And she wanted to take me for a ride. I chickened out. That was it. Now she's in Florida at college or whatever it is she does, but it's pretty impressive to see a 17-year-old piloting her own airplane.
Wow.
And I think I'm chicken out.
But I still won't ride.
Yeah.
Did you catch any deer? That's the question.
I didn't hunt this year. My family had some issues. And I just, so got some health issues in the family. Too much. Everything's fine, so I'm happy.
Oh, good.
Good.
Lori Houghton, I represent the city of Essex Junction, and I spent a lot of time in Maine this summer with my family, which was really fantastic. And my son is a senior, so we're in the midst of like waiting to hear from colleges, which is pretty exciting. And I think what I want to work on and continue working on is kind of gets to the affordability piece, and that is still continuing the work on the transformation we're trying to do of the health.
Yes. I'm Leslie Goldman. I represent the Bells Falls area. My biggest adventure this summer is I took a medical mission to Papua New Guinea, which was an enormous adventure. And I was working on a thread with village birth attendants. So these were women who had no education and learned their craft being handed over by their peers and older people. And what was really moving to me was the universality of a woman's experience of birth. They were asking the exact same questions about how to manage birth that we ask here in our hospitals. So I was just really, what am I interested in? I'm interested in making healthcare affordable, accessible, having better outcomes, stabilizing our hospitals. I'm from the South. We're hearing a lot about Brattleboro. I'm worried about that. How do we support that? So those are the questions I'm entering. It's very broad. And yeah, it's a bit of a mystery.
I know it's only been a few hours. Any priorities or did you do anything fun in summer? Winter, summer?
That's a good question. I mean, it was a good summer. I don't really, ever since mid-October, it's kind of a blur. But you know, as to healthcare, really, everything everyone has said is really, really important. I think making sure we have primary access to primary healthcare, and that you know those resources are available, because not only is it more cost effective, and at least better outcomes, it's a better use of money. And having people in the hospital when they shouldn't be there is a poor use of money. And so I'm glad that the legislation passed last year has some mechanisms. I'm glad about the, you know, the federal award, and just wanting to be really thoughtful and careful systemically about how that can improve affordability. But that's it.
Deb, our new clerk.
Yay.
Hey.
Recall at the end of the year, since Mari had previously been the clerk of House Healthcare for many years, Deb is going to take over that role.
She's a big, loosely folded justification on her.
Yeah.
Thank you, Deb.
Thank you, Deb.
I might have got voluntold. Debbie Powers, I represent Waterford, Barnet, Reigate. And I do want healthcare to be more accessible and affordable. And health insurance also.
My name is Tobin McFarland. I represent Barrytown and parts of Williamstown. I've been in the legislature for 21 years. This will be 22. Oh, no
Did you have a great
reaction to
summer?
that? Get into that, get into that. No, I did not have a good summer. My wife was injured, and we spent most of the summer in either the hospital or the rehab center. So she's doing okay now. What am I interested in? Reconstructing the healthcare system so that it's more accessible, keep the quality, and it costs less. And I have to tell you, I've been working on that for all the time I've been in the legislature. It's starting to come to fruition now. My buddy over here and over there have helped it come that way too. So that's essentially what I've got to say. You'll get to know me. You're gonna have some fun with me, for sure. And I'm gonna have fun with you as we go through this process. Because we get a lot on the table this time. And I'm hoping that we're gonna move the right way. And we're all gonna be involved in it.
I'm gonna skip over myself and go to
saving the best for last. I'm Daisy Verbecco. I represent Winooski. And let's see, I had a great break, although I'm going to be totally honest, and I suspect it similar to some of you, it wasn't much of a break. I worked with a lot of our stakeholders over the summer. There were multiple healthcare emergencies that, you know, don't wait for us to get back in session to fix. I mean, we're a citizen legislature, but we represent our communities 365 days a year. So I had a great time back in my community and really reconnecting with them, and especially two of my favorite constituents, Oliver and Cambria, my kids, who all of you have met, and Val and Karen, you'll meet them too. My priorities for this year is I want to help facilitate like better communication among the committee. So us getting together, doing breakfast more, supporting Alyssa and coordinating things like that. And my policy priorities remain rooted in making sure that we don't forget mental health care, and especially youth mental health. And right now our providers really could use our support. They're barely making ends meet. So helping to make sure that we're always remembering them is my goal this session, and just getting to know everybody a little bit more deeper so we can do good work together.
And I forgot something. And the chair, as usual, allows me to speak once in a while.
Whatever you want.
Since I talked about a negative thing about the summer, after the summer was over, and Christmas holidays and all that came around, I had one of the most wonderful Christmases I've ever had in my life. I have 6 grandchildren, and they're all over the world. And my wife and I got a call from one that was on the ski lift in Jackson Hole, going up on the ski lift, and he says, "I just want to tell you that I love you too." I had another kid call from Mexico, and he said the same thing. And he was he and his wife, new wife, went back to the place where they met. And I remember the Christmas that he didn't come home. And I was sitting there, and his mother was there. And his mother said, "What's her name?" And that's what it was. So they went back to there. One of my grandchildren came from Belgium, and she was present. The 2 youngest grandchildren were present. And one of my grandchildren, she was in the hospital. She called from the hospital bed and said, because she was planning to be there, but she got sick. So my wife and I had a wonderful Christmas. So the whole year wasn't ruined by that summer. We had some good times too. Thank you, Madam Chair.
I'm glad you had a wonderful Christmas,
Thank
because
you.
I do know that you were intimately acquainted with our healthcare system.
I sure was.
So I'm Alyssa Black. I represent Essex. Today, because January 6th is obviously a date that you remember. So I was sworn in exactly 5 years ago, 2021. I was kind of reflecting on this a little bit in the last couple of days. I had a pretty good off session. I really prioritized some things in my life. I did some great travel. I was in Greece. I was recently in London, but I actually got to go to Istanbul, which has been number 2 on my lifetime bucket list. And I just absolutely thoroughly enjoyed that. So I've gotten some great travel. I've gotten to spend some wonderful time with family and friends. I took down, I think the highlight for me, strangely enough, which is a little sad, I was taking down my Christmas tree on Sunday. And I was so sad that I was taking down my Christmas tree because my house had just looked beautiful with it. And I had all these decorations that I've been accumulating over the last 8 years, and they have never seen the light of day. It's the first time I put up a Christmas tree in 8 years. And it's the first time I've decorated, and it's frankly the first time I've actually really celebrated Christmas. So, and that was celebrating Christmas for me was the highlight of my year. But now we're back here and the tree's out on the curb waiting for the town of Essex to come pick it up.
Very symbolic.
So, priorities, we have a ton of priorities. I'm gonna cite Nolan every single time I just did a radio thing with VPR, Vermont Public, I'm sorry, I still call it VPR. And, last year we dealt with so many like emerging crises. And, if you went through our YouTube and you stacked up every single person that sat in this witness chair and said, things like crisis, heading off the cliff. What we dealt with Blue Cross Blue Shield of Vermont, what we dealt with UVM Health Network, what we did around 340B and price cap, reference-based pricing, all of the things that we dealt with. First of all, we did amazing work last year, just absolutely amazing work. The house was on fire. The house is still on fire. It's still on fire. And it is incumbent upon us to ensure that what we do here, sitting around this table for the next 5 months, is that we have oversight and accountability for all the things that we've put in place. We had a couple of HROC meetings this off session, and we set some very, very tight timelines last year. And, to Lori's point about hospital transformation, give them till 2029. And I am deeply concerned that if we don't move quickly and move forward on hospital transformation, we might not have any hospitals to actually transform. So we're still on fire. A family last year at 400% of the poverty level, which is solidly middle class, paid over $10,000 a year for a family of 4. And this year on the exchange, they're paying $52,000 a year. That, under any definition, is not affordable. So that's what we need. Everybody around here had a theme of affordability, and we will be continuing the work that we started last year and building upon that work. So that is my hope. Yes.
I just realized that the new members told us what they did besides being a legislator, but I don't know if anyone else said to them what they do besides being a legislator. And I wondered if maybe we can quickly each do that so that they know that this isn't just all we do.
Oh, well, speaking of,
Yeah.
speaking as of what I did this summer, I spent an enormous amount of time in the business that I now work in as, I'm calling myself the CFO. It's really not that big of a CFO. And I am learning all sorts of new, fun, fascinating things about automotive repair. And a couple people sitting around this room, it got to the point where I was having to leave so often, and my business partner would give me like a shifty eye about where. So I believe 3 separate people in the last month have, and I'm going to cite a former senator, they're like, oh, it's just like Dick Mazza.
Oh, no.
Because now I'm making everybody come to the automotive repair. To have you. If you want to talk to me, we're going upstairs. It's great. So, yeah, Dick Mazza famously would only meet people at his store in. So that's what I do in the off session. In charge of the financials of an automotive repair business.
You want me to go next?
Yeah, let's go in reverse order.
Yeah, but we've got to get moving here
Yeah.
because Jen is scheduled in 2 minutes.
Yeah. And can I put one thing on the table? Because I'm facing you guys and I'm looking at the guiding principles, so we may want to talk to our new members about those at some point.
Actually, let's get more information about each other as throughout, because there were a couple things I wanted to say, just really business wise. First of all, yes, our guiding principles. And I famously am the person that had a meltdown over why are we spending all the time on this? This was years ago, and when Lori sat in the seat.
But you embraced it. I embraced it.
I embarrassingly, and I've actually used some of them in floor reports. I look up to them all the time and I think, oh, yeah, that's what we're doing. A couple housekeeping things. All I ask from you is that you be on time. Our witnesses deserve the respect of us being on time. Their time is important. Please make an effort to be on time in committee. If you're not going to be here, if you're going to be late, let someone know. Tasha. Oh my gosh.
Yeah.
Oh, I'm the worst. I forgot. We need to introduce our new committee assistant.
Hi, everybody. I'm Tasha Kuffner. I'm the new committee assistant. It's nice to meet all of you, and I look forward to working with you over the next few months.
We are so thrilled to have you.
Yes.
So thrilled, despite the fact that I just spent 30 minutes and
That's
but
okay.
we're really thrilled to have you. Looking forward to it. So everybody get Tasha's number if you're going to be late, or if you aren't able to make it, please let somebody know. So we're not waiting on you. Again, I find it's a respect thing for our witnesses. Their time is important, just like our time is important. Also, I did want to, I wanted to mention something, two things about respect. And I said this at the beginning of last year, and I just want to set a reminder that we have in our committee, we're served by our staff. And in particular, we have Nolan from JFO, we have Jen Carby from Legislative Council, and we oftentimes as well have Katie McClin from Legislative Council. Our staff works for all of us, but please be respectful of our staff's time. And, you know, if there are things that you can find out on your own, find them out on your own. Don't burden them, because they're really, really, really busy. I mean, heck, you saw all the bills they had to write. And I was thinking about you on the floor today, because every other bill, it seemed like healthcare, and I'm like, oh, poor Jen Harvey.
No.
She's been busy. She hasn't been traveling all over the world in the last. So please be respectful of our staff, even though they work for all of us. And I do appreciate that. The other thing I want to say is we had a couple incidents last year, and I really want people to reflect and think on this a little bit. We deal with some topics in here that are deeply, deeply personal to all of us. I mean, we're dealing with the health and the lives of Vermonters. And I want us to remember that the witnesses that sit in our chair they're people too. And they deserve our respect And we did have a couple incidents last year of which I take full responsibility. But there were some times when we were not respectful and we turned a few of the things that happened with some witnesses, we turned them into personal and almost in a way personally attacking the witness. We should never, ever do that. And I just want you to know that I'm going to be very, very cognizant of that this year. These people are here to give us information and help us. But we do not need to ever attack anyone personally or make comments personally. And I'm not going to go into the specific situations, but I just want us to remember that the people that they're doing their job, and they're here doing their job and they deserve respect. And so let's try to keep our comments in professional and not get into the personal realm. I think that was it.
I'll add one thing too.
Oh, of course, you always have to.
No. That, what she's just talking about, that goes for all of us too. We have to respect each other. We have to work together. We may have different ideas. We may feel differently about a particular subject or the way we're going to solve a problem. But remember, it comes from the heart from everybody. And just work together and respect each other. And we'll get a lot of good things done. Thank you.
Yeah.
You got the last word.
Well, I was gonna say, the speaker asked for my well, she did actually, frankly, she didn't ask for my input. But I did know that I was gonna be getting 2 new committee members. And my only directive to the speaker was, I don't care if anyone has healthcare experience. I can teach, or I can't, staff can. People will learn. I'm not worried about that at all. I think that it goes for every single person that sits around this table. That I just want people who have a core set of values, and I always want you to follow your core set of values, even if they are at odds with someone else. That is your job, and that is why you're representing your constituents, and that's why they've elected you. So always do that. Okay. Let's have Jen come up. Sorry, I went into your time. Oh, wow, I really went into your time. I'm so sorry. So I wanted Jen to do an overview of what we did last year and updates of things that have happened. Because I think even I sometimes forget what we did.
Well, good afternoon, Jen Carby from the Office of Legislative Counsel. Nice to see those of you who are returning, and welcome to those of you who are new. Look forward to working with all of you. So I am one of the 2 attorneys who spends the most time in this committee from the Office of Legislative Counsel. And I'm going to take you, most of you, on a little walk down memory lane, all the exciting things you worked on last year. And there were a lot of things, even some of them I didn't remember because you were quite busy. So I put together a presentation, hopefully I can easily make work.
Do we have this posted on our page? Not yet, but I will post it. Okay. Okay. Realizing we have no date for today. Date on the webpage.
Okay.
Okay, so what did you pass in 2025? And by which I mean, what bills that went through this committee became law? And there's one in here that spent a little time in your committee, but has some relevance, so I included it as well. I need these controls somewhere else because they're blocking my content. All right, so the first thing you did and became Act 2, so very early on in the session, was to permanently unmerge the individual and small group health insurance markets. And that took effect just a few days ago on January 1st. These markets had been merged as part of the implementation of the Affordable Care Act. They had been temporarily unmerged on a year or 2 basis since 2022. And last year, after testimony from many different stakeholders who advised this course of action, permanently unmerged those two markets. So now they have separate premiums, separate risk pools. Act 3, you did some sort of cleanup work on a bill you had worked on the year before, or some of you had worked on the year before, on claim edit standards. So health insurance claim edit standards and prior authorization requirements. There have been a couple of issues that came up after the 2024 session. There was some recommendation to address, again, pretty early in the 2025 session. So the first one was dealing with what happens when there are healthcare services delivered outside Vermont, and how do Vermont's requirements on claim edit standards apply? And so language was added to specify that those out-of-state services are exempt from our required claim edit standards that health insurers have to follow, unless the insurer and the out-of-state provider agree that one or more of them will apply. Should I question? Okay. Okay. The second was to define primary care. So there was an exemption from prior authorization requirements added in 2024 for services ordered by a primary care provider. And there was a definition that wasn't providing sufficient clarity. So this added a definition saying a primary care provider, for purposes of the exemption from prior authorization requirements, is a provider who is contracted and enrolled with the health plan as a primary care provider. So if they meet the health plan's standards to be a primary care provider, then they will be exempt from that carrier's prior authorization requirements for most services. Act 6 dealt with the Office of the Healthcare Advocate. So there was some language throughout the bill that expanded the scope. The Office of the Healthcare Advocate language had dealt really primarily with health insurance, and this broadened it to reflect the role that they have assumed over the years, which is really addressing affordability and access to care for all Vermonters and not just those on health insurance. It also expanded the advocate's ability to ask questions during the health insurance rate filing process. It requires the Green Mountain Care Board, so even though it's in the Healthcare Advocate bill, this is requiring the Green Mountain Care Board to make the whole record of a health insurance rate review available to the public. They have to redact confidential information, but otherwise the whole file becomes public. It also enlarged the role of both the healthcare advocate and kind of their counterpart for long-term care, the long-term care ombudsman's office, when they intervene in an application for a certificate of need. We'll see more about certificates of need coming up. And it has some fairly broad language requiring state agencies to seek input from the healthcare advocate when they're developing policies affecting healthcare access and affordability, and to provide, or I keep having to move my bar around, provide access to the healthcare advocate to confidential or proprietary information when appropriate, as long as the healthcare advocate's office does not further disclose that information. That was Act 6. Act 9, this is the only one in this slide deck that I didn't draft, so you will all have more familiarity with it than I do. This is one that Katie worked on with you. But this requires hospitals to develop and implement security plans for preventing workplace violence and managing aggressive behaviors. And that had to be based on the results of having a security risk assessment done for each hospital. Then hospitals must use a workplace violence incident reporting system to document, track, analyze, and evaluate any instances of workplace violence. It excluded from certificate of need requirements hospital expenditures that are necessary to implement the security plan, and it requires hospitals to report the costs of implementing their security plan as part of the hospital budget review process, so that the board can take those costs into account when establishing hospital budgets. Hopefully this looks familiar to you.
When did that go into effect, Jen? That required updating the Green Mountain Care Board?
I don't know. I don't know if anybody in the room was following this enough to know.
Last year.
Yeah, I can.
I know they're already working on.
I tried to put in the effective date if it was something sort of unusual, but for the most part, these were, I think, effective like July 1st of 2025, but I can take a look. I think the idea was just that these costs should be accounted for in the hospital budgeting process, and hospitals shouldn't be, shouldn't be dinged on their hospital budgets because they were having to implement them.
I just looked at your act, I'm assuming you wrote the act
Katie
summary,
did, because this was Katie's bill.
and it says July 1st, 2025.
Okay, great. All right, now we're back to my bills.
Okay.
Act 11, very large bill, very short write-up. This was updating and reorganizing the health insurance statutes in 8 VSA Chapter 107. This is my labor of love project.
Was this mine too?
Yes, this was
Yes, I think it was ours. Yes. And so this has been great. We overhauled the chapter. In this committee, we talked about the effective date, which you changed to September 1st of 2025, which worked out great because I was able to get it incorporated into the brand new, hopefully up there, Title 8 Part 1 book. So going forward, it will always be in the Green Book as the new version. All right, Act 14. This is the one that did not spend a lot of time in this committee. It was mostly my asterisk there. It was mostly down the hall in House Human Services, but because it deals with, among others, the designated and specialized service agencies, I wanted to make sure to point it out. So this is Medicaid rates for community-based service providers. And this act requires the Secretary of Human Services to calculate payment rates for providers of community-based services, and it specifically includes the DAs and SSAs in the Medicaid program that are reasonable and adequate to achieve the required outcomes for the populations they serve. And then it directs the Secretary to establish a methodology for calculating those rates that includes a schedule for conducting Medicaid rate studies. So they're continuing to kind of do a deep dive on different provider type Medicaid rates. Set out a predictable timeline for redetermining base rates, and come up with a process for calculating an annual inflationary rate adjustment. So the important piece to remember is this next bullet, which is it directs the Secretary to recalculate, to do the math, at least annually, and report those rates and the cost of funding them annually as part of the agency's budget presentation, but it doesn't automatically commit the legislature to funding them. So this is really an effort to have you have, at least from the agency's perspective, kind of the official word on what they should be getting paid and how much less, if it's less, they are being paid, and what that gulf looks like so you can make decisions on how you want to appropriate money. It also directs the Secretary to establish a process for providers to request stabilization assistance from the agency if they're at imminent risk of closure. So this is sort of analogous to the nursing home extraordinary financial relief, but there was interest from the agency in not using that same terminology here. So it's provider stabilization, but same idea if they're at imminent risk of going under. And it requires the agency to provide an implementation update on this act by January 15th. So next week, you should be getting, right, an update on this. That report has not come in yet to my knowledge. Great. Next is Act 15, which is, again, can't see the title, but something having to do with certificates of need. It increases the monetary thresholds for when a certificate of need, a CON, is required. So you might remember it also, and it aligned the triggers for hospitals with those for other healthcare facilities. Remember, for those of you who were here last year, we used to have two sets of triggers that were a little bit different if it was a hospital or a healthcare facility other than a hospital, and you significantly increased the monetary thresholds and left most of the non-monetary thresholds in place, but just have one set of rules for all facilities. And in addition to some new CON exclusions added in some other bills from last year, including the hospital security plan and the freestanding birth centers we'll see coming up, you added new CON exclusions in this bill for fully depreciated medical equipment, ground ambulance services, and emergency medical equipment and supplies, and new services or projects for facilities that are owned or operated by the state or funded by a contractor grant from the state, but you did put in a notice requirement. So the Green Mountain Care Board would have to get notice that this new project is happening. But the discussion in this committee was if there has been a decision made by another part of state government that a particular service or construction project is appropriate. It shouldn't have to go through a certificate of need process, but there should still be that awareness for the board. So far, so good. Hopefully these are sounding familiar to most of you. All right. Act 19 was the licensure of freestanding birth centers. You created licensure requirements for freestanding birth centers and directed the Department of Health to adopt rules, including the requirements for operating a birth center, what scope of services a birth center can offer, and requirements for written practice guidelines and policies that include transfer procedures if a patient needs to go to a hospital, in collaboration with other providers who would be providing services to the same patient. Here we have another exemption from the CON requirements for these birth centers, and the language required health insurance plans that cover maternity services to cover those services when they're provided at a birth center. And you also directed the Agency of Human Services to seek federal approval for Medicaid coverage of services provided at a birth center. Section 20, dealing with what I've termed certain legally protected healthcare services. Some of you may remember from 2023, that term legally protected healthcare services deals with access to reproductive healthcare services and gender affirming healthcare services. And so there was an Act 15 of 2023, along with Act 14 that went through the judiciary committees, did a lot of work on that topic. The one that went through this committee was really focused on the healthcare side of things. Act 20, S28 from last year made some updates and additional provisions. The first was to create some reciprocity language with other states that protect access to reproductive and gender affirming care. Basically saying if a provider, we have a lot of protections in Vermont law for providers who deliver these services in Vermont. If a provider from another state who was acting under that state's similar legally protected healthcare kind of laws provided services there that would have been permissible if they were provided here by a licensed provider, if that provider comes to Vermont, Vermont will extend the same kinds of protections, including not cooperating with extradition proceedings for that provider as though they were a Vermont provider.
I can look it up, but I think the group should know the answer to a question. Can you remind us of how it expanded the scope of conduct that violated the Consumer Protection Act? If it's not easy to do, I'll look it up and we can talk about it.
Yes, but let me just get to that first. Still just on bullet number 1.
Oh, I thought you read through them already.
No.
That's funny. I'm like, I went through them and she's talking and I'm like,
She was
okay.
still on the recipe.
My bad.
We're talking about reciprocity.
Okay, sorry.
Okay. So the second bullet here is to exempt records that are held by the state's professional licensing entities from disclosure under the Public Records Act if they contain personal contact information for the applicant or licensee other than an address that the applicant or licensee designated as a public address. So this is to keep their personal home and phone number, home address, phone numbers, things like that from being disclosable under the Public Records Act. It amended the unprofessional conduct laws for several healthcare professions to add as unprofessional conduct advertising that is misleading or has a tendency to mislead, and for letting someone's name or license be used if they are not actively overseeing the services that are being provided in their name or under their license. The act allowed a healthcare provider to prescribe medication to terminate a pregnancy based on an adaptive questionnaire that will allow the provider to ask follow-up questions if needed. A lot of discussion in this committee on that. This is the bullet that that Representative Sheena was asking about. So the act expands the scope of healthcare-related conduct that violates the Consumer Protection Act. Previously, the language had been specifically around limited services pregnancy centers. This expands that to apply to anybody offering health or doing advertising relating to healthcare services in this state. So regardless of setting. It also added federal investigations and proceedings to non-cooperation language. The 2023 legislation, particularly on the judiciary side, had language in it directing state employees and officials not to use any of their time or resources to assist in an out-of-state investigation into somebody who was providing providing or receiving legally protected healthcare services, if that was in order to impose civil or criminal liability on them. This is adding federal investigations as well. So directing that nobody in state employment should be dedicating time or resources to cooperating with a federal investigation or proceeding that's seeking to impose liability for legally protected healthcare activities. Modified the limits on disclosure of protected health information related to legally protected healthcare activity, including, again, adding some limits on disclosure to the federal government that otherwise would be permissible under HIPAA, but this would say under Vermont law it is not. And finally, it allowed prescribers and pharmacists to have their names removed from prescriptions for medications for reproductive and gender-affirming healthcare services.
That is the discussion I remember the most.
Yes. It was also an expensive.
Thanks for bringing that back.
Sure. We'll move on. Act 21. This was medical debt relief and removing medical debt from credit reports. This is a proposal from the Treasurer's Office. They requested and you approved appropriating $1 million to the Treasurer's Office to contract with a nonprofit entity to acquire and repay certain medical debts incurred by Vermonters. If you remember, those of you who are here, they were going to be, because they were old, it was old debt, they were going to be acquiring them for significantly less than the original debt. And so that's about $1 million would go significantly further than just $1 million in debt. To be eligible, there were certain requirements around the debtor. They must be a Vermont resident. They must either have household income not greater than 400% of the federal poverty level, or owe medical debt that is 5% or more of their household income. And their patient account still has to have an outstanding balance even after the provider has done their normal collection efforts. This act also added a definition of behavioral health to Title I of the statutes for certain purposes, which wasn't all that relevant to this bill, but is in there. It allowed nonprofits to request a consumer's credit report without the consumer's permission. So to pull credit without permission in order to determine their eligibility for abolition of medical debt. Usually you have to get the consumer's permission to pull their credit, except for certain purposes. This added determining eligibility for abolition of medical debt to those purposes. It prohibits credit reporting agencies from reporting medical debts or maintaining medical debt information in a consumer's file. And it prohibits large healthcare facilities, hospitals, ambulatory surgical centers, things like that, and medical debt collectors from reporting medical debts to consumer reporting agencies.
Just an FYI, we're asking the Treasurer's Office to come in next week to give us an update on this, to see how it's going, what they've spent, what they've been able to accomplish so far. So looking forward to that.
Yes. All right. I'd say we're almost done, but we're not almost done. Partly because I have a lot of slides on Act 68, which was the healthcare reform one you spent a lot of time on. Act 49 is the Green Mountain Care Board's authority over to change hospital reimbursement rates and appoint a hospital observer. So this act allows the Green Mountain Care Board to reduce a domestic health insurer, which is really statute speak for Blue Cross Blue Shield of Vermont. So allows the Green Mountain Care Board to reduce Blue Cross Blue Shield of Vermont's reimbursement rates to one or more Vermont hospitals if that insurer faces an acute and immediate threat of insolvency. And some of these are terms that are defined in the existing statute. There are certain parameters, and the board can only reduce rates to hospitals that meet certain fiscal criteria, and they have to be in relatively good fiscal health. And they can only reduce rates to the extent necessary to address the threat of the insurer becoming insolvent. So you put some safeguards around it, but that is a new authority for the board. You directed the board in setting hospital budgets to account for any significant deviation in the hospital's revenue during the previous fiscal year in excess of its approved budget. So they can do some kind of truing up in future years. You allowed the Greenmount Care Board to adjust hospitals' commercial health insurance reimbursement rates at any time during the year to ensure the hospitals stay within their approved budgets. So they can make more changes than just at budget time. And at least for a few years, you've allowed the Greenmount Care Board to appoint an independent hospital observer under certain circumstances. And this is really to go in and look at and work with a hospital that may have made one of the criteria is made a material misrepresentation in their budget filings, or I think has made a material deviation from their approved budget. This authority is repealed on January 1st, 2030, unless you extend it. There's a concern, particularly from the hospitals, about this being an open-ended authority. And so this would at least require a revisiting.
I should know this, since I actually reported this bill. Were there any other circumstances that we allowed for an appointment? Did it have to be material misrepresentation? Was that an and or an or?
I have to get out of this for a second to look, so give me a second. See if I can look things up here. It was an or, you didn't have to meet multiple criteria, but let's see, Act 49. So the language on this is the board may, upon finding the hospital has made a material misrepresentation in information or documents provided to the board, or that a hospital is materially non-compliant with the budget established by the board, appoint an independent observer. So those are the two permissible criteria, either material misrepresentation in something provided to the board or materially non-compliant with their budget.
Okay, thanks.
Act 50, certification of community-based perinatal doulas and Medicaid coverage for doula services. This created a voluntary certification process for community-based perinatal doulas through the Office of Professional Regulation, and required the Department of Vermont Health Access to reimburse certified community-based perinatal doulas for providing services to Medicaid beneficiaries during pregnancy, labor, delivery, and postpartum. The reason, as you may recall, that it's a voluntary certification process, it's not required. You could still be a doula, a perinatal doula, or even a community-based perinatal doula without getting certified, but only certified community-based perinatal doulas could be reimbursed through the Medicaid program. So that was the rationale for the voluntary certification. You expressed legislative intent that the reimbursement rates for these doulas should be reasonable and adequate for the services provided and consistent with rates set by other states' Medicaid programs for doula services. And you directed DVHA to seek a federal state plan amendment by July 1st of 2026 to allow Vermont Medicaid to pay for doula services. Act 55. Yeah, go back.
Just a quick question about that. So they have to seek it, but it doesn't mean that we'll get it. And that process may be long.
I think that they're going to be updating us on this.
Okay.
Yes. Next, we have Act 55, which is the 340B prescription drug pricing program. And we never changed the title, so I just gave you the parenthetical reminder that this is where the cap on outpatient administered drugs lives. So this restricts certain actions by prescription drug manufacturers regarding 340B contract pharmacies, 340B drugs, and patients of 340B covered entities. And it creates a private right of action for anyone who is injured or harmed by a manufacturer's failure to comply with the prohibitions and requirements. And we may be hearing about there's some active litigation. You may recall getting a litigation hold notice through maybe me from the Attorney General's office. And there is active litigation on many parts of this. So this may be part of a future conversation as well. The Act required hospitals to report information about their participation in the 340B program to the Green Mountain Care Board by January 31st annually get these reports through 2030. And it directs the Green Mountain Care Board to post those reports on its website. So we still have a few weeks. I didn't see anything up there, but hopefully they're making space for that on the Green Mountain Care Board website. And then the cap part that I think is getting most attention is that it caps the amounts that hospitals can charge health insurers for prescription drugs that are administered in an outpatient setting. And that cap is set at 120% of the April 1st, 2025 average sales price. So if you remember, those of you who were here when we worked on this, it was after April 1st, 2025. That's why we picked a past date certain so that we knew what those numbers were. If a hospital was already charging less than 120% of the average sales price on April 1st, 2025, then the cap was the actual percentage of average sales price on that date. So it didn't allow them to go up to 120%. It capped it at whatever it was on that date. There were some additional provisions. A hospital can ask the Green Mountain Care Board to increase its reimbursement rates for other service lines if it can show that the price caps are negatively affecting access to care, quality of care, or the sustainability of rural healthcare services. It specified that the price caps will remain in place unless and until the Green Mountain Care Board sets a different reference-based price that applies to these drugs. And we're going to talk more about reference-based pricing in a moment. And it carved out certain types of hospitals. These price caps do not apply to independent critical access hospitals that are not affiliated with another hospital or hospital network. So these are only non-critical access hospitals. Yes, it applies only to non-critical access hospitals and critical access hospitals that are affiliated with another hospital or hospital network. All right, we're down to the last two. Act 62 was an act relating to modifying the regulatory duties of the Green Mountain Care Board. It changed or eliminated some Green Mountain Care Board duties, including those having to do with health information technology and vital Vermont information technology leaders. The board had been responsible for approving the state health information technology plan, for reviewing and approving Vital's budget, and some other HIT related standards that have largely shifted to other entities in state government. It eliminated the 8% allocation for accountable care organizations in the Green Mountain Care Board's bill back formula. The Green Mountain Care Board is able to bill back the entities it regulates for a portion of the cost of regulating them. With OneCare winding down at the end of 2025, there was not going to be a lot of action on the accountable care organization front. And so there really was not 8%. Having an 8% allocation for ACOs didn't seem to make sense anymore. So you took that out. It significantly modified the ACO certification and budget review processes, including recognizing the need to certify Medicare-only ACOs and the less need to do budget review except for potential future ACO that would contract with Medicaid or commercial insurance or both. Also set fees for ACO certification and budget review processes. It specified that the board's regulation of hospital budgets does not constitute a contested case under the Vermont Administrative Procedures Act. I remember some lively testimony on that. And a reminder that aggrieved parties have the existing ability to appeal under the Green Mountain Care Board's appeal statute, which is an appeal directly to the Vermont Supreme Court. It modified the scope of some requirements around meetings of an ACO's governing body to apply only to ACOs that contract with Vermont Medicaid, which I think few or none as of now. And it eliminated some language requiring the Green Mountain Care Board to do an annual advisory rate case. So kind of doing rate case as if Medicaid was an insurer for the all-inclusive population-based payment arrangements between DVA and an ACO. This is really sort of more timely in the all-payer model time. And had the Green Mountain Care Board doing nothing binding, but sort of giving its 2 cents on whether the rates were appropriate. So that was eliminated.
I like to call this the articulatable nexus.
Yeah, I forgot
I
about
think
that.
I think that was the HCA bill.
Was it?
It was, I think it had to do with the health insurance rate review.
One that Wendy.
Almost reporting. I'm still trying to get it out of my mind. Yeah.
Still can't say articulatable.
Good a reason as any. All right, lastly, but 5 slides worth, we have Act 68, which was S-126. And we have to get used to the new numbers, Act 68, and this is the Healthcare Delivery and Payment System Reform Bill. This one did a lot of things, and I think you'll be hearing some, particularly on this one, some follow-up in the next days and weeks. So the first thing it did was to require the Green Mountain Care Board to establish reference-based prices. And these are prices that represent the maximum amounts that Vermont hospitals can accept as payment in full for items or services delivered in Vermont. And the reference-based prices are based on a percentage of the Medicare rates for the same or a similar item or service, or a different benchmark as appropriate. So the term reference-based pricing is using a reference, in this case, Medicare rates or something else, as the basis for whatever the price is. So it could be 120% of Medicare, it could be 250% of Medicare if they're using Medicare, but something based off of kind of a known constant, which in this case could be the Medicare rate or something else. So it's the Green Mountain Care Board is supposed to start. They were supposed to start as soon as practicable, but not later than hospital fiscal year 2027, which actually starts October 1st, 2026. So start as soon as practicable, but not later than sometime in that year that begins October 1st, 2026. The board will review, once it sets them, it will review reference-based prices for each hospital annually during their annual budget review. So this does mean that reference-based prices may not be the same for each hospital for each item or service. Specified that balance billing is not permitted, so the hospital can't get the reference-based priced amount from the insurer and then bill the patient for some additional amount. That would be balance billing. And it requires the board, in collaboration with the Department of Financial Regulation, to monitor implementation of using these reference-based prices. This is really to get some control over prices, over what's being paid, to ensure that decreased payments to hospitals result in decreased health insurance premiums. It's not necessarily a one-to-one, but the idea was to be monitoring this to make sure it's having the intended effect. There's also, it does say this in here too. So it allows the board to, in consultation with the Agency of Human Services and others, to look at setting reference-based prices for services delivered outside a hospital, like primary care services. And there had been conversation last year, perhaps making those reference-based price amounts higher in order to incentivize more care in the community, or if that's the appropriate setting. So that's some of the work that they will be doing in the future. And it does specify that the board's reference-based pricing authority does not apply to rates paid by Medicare or Medicaid. For Medicare, we don't have the authority. For Medicaid, we have a whole separate process through the Agency of Human Services and DVA for paying providers. So this is just reference-based pricing.
This thing no later than 27 fiscal year. What is the fiscal year of the hospitals? Is it July 1?
No, it's October 1st to September 30th for all of the general hospitals. And then as of last year, you've allowed Brattleboro Retreat more officially to keep a calendar year. But for the rest of them, they follow the federal fiscal year, which kind of makes sense since they're used a lot of Medicare.
Put that in the bill?
This date,
Yeah, did we put that in there?
by we use
The fiscal
this
year.
committee as opposed to the downstairs committee, I don't recall. I think it started downstairs,
Not that date.
not that date.
Not that date.
Okay. There was a lot of talk about dates. I think there was the tension between wanting to get this reference pricing going as soon as possible and the board saying we need time to figure out how to do it first. So it's still a little squishy with the soon as practicable, but not later than over a course of a year. But you'll get an update from them on how that's going.
But it does say in there, will start.
Yes. Yes, that's true too. It does not, so it doesn't mean, right, doesn't mean they have to be setting all all prices for all services at all hospitals.
Start.
They gotta start. Also in this act, the language requires the Green Mountain Care Board to establish global hospital budgets if resources to do so are available for one or more non-critical access hospitals by, again, hospital fiscal year 2027, and for all Vermont hospitals by hospital fiscal year 2030. Again, this is, I think, was trying to find some middle ground between wanting to keep moving forward toward global hospital budgets and recognizing that the resources may not have been provided to the board to do that work in addition to the reference-based pricing and other responsibilities. Then separately, the act requires a hospital that is proposing to reduce or eliminate a service to comply with its hospital budget order must provide a notice of intent to the Green Mountain Care Board, the Agency of Human Services, the Office of the Healthcare Advocate, and the legislators who represent the hospital service area at least 45 days before they actually reduce or eliminate the service. And it allows the board to modify a hospital's budget or take other action to preserve access to necessary services. The act gave the Green Mountain Care Board the authority to oversee hospital networks that derive 50% or more of operating revenue from Vermont hospitals. There had not been specific authority to regulate or oversee hospital networks. The board can recommend, but not require, actions necessary that it finds necessary to correct aspects of the network or its financial operations that are inconsistent with the principles for healthcare reform, sometimes called the Act 48 principles, or the statewide healthcare delivery strategic plan once that's established. Coming up, I think, on the next slide. And then also unrelated, but I sort of went through in the order in which they appear in the act. The act requires payers and providers to provide an unredacted copy of an executed or proposed healthcare contract between payers and providers to DFR or the Green Mountain Care Board upon request. So to give them more insight into what is in these contracts.
Could you just say what a global hospital budget is briefly, or is that?
Great question. Well,
So-
it was asked a million times.
Yeah,
last year.
and also
Answered in a lot.
it's around, well, no, it sort of depends. I think there are different ways of defining it. And so I think some of that is going to be what the board will be determining.
I believe, did it stay through conference committee that we actually had in there define what a
I think it
global
does.
budget
I
is?
think that is part of what's in there. Yes.
Everybody.
People, yes. It's in the eye of the
Well, it's in
beholder.
the eye of the beholder. Exactly. That's a good way to.
So yes, it needs defining before it really happens, but it is not a specific thing. All right, the act also directed the Agency of Human Services in collaboration with stakeholders to lead development of that statewide healthcare delivery strategic plan. The plan is due to you all by January 15th of 2028. And there's some interim steps in there as well specified. And then the agency has to update the plan every 3 years, with the first updated plan due by December 1st, 2030. So not quite 3 years, so that you have it before the session begins. The act created an 18-member healthcare delivery advisory committee and a 16-member Vermont steering committee for comprehensive primary healthcare. We can revisit all of these in more detail if you want. It directed the Agency of Human Services to collaborate with the existing Health Information Exchange Steering Committee to develop or continue to develop the Unified Health Data Space. It specified some elements of the development process, including determining whether it makes sense to integrate clinical and claims data, and if so, how to do so in a way that protects proprietary information. This is definitely one that was hashed out in conference. The integration of clinical and claims data, if it's going to happen, cannot begin before next January, and then only if a majority of the steering committee votes in favor of proceeding. And there's a report on integration of clinical and claims data and whether it makes sense and how it would work. All of that due to you by sometime next week, with annual updates on the development and implementation of the Unified Health Data Space due beginning next year. The act authorizes the Green Mountain Care Board to share any materials, so a different topic again, it receives pursuant to subpoena, it has subpoena power. The act now authorizes the board to share anything it receives pursuant to its subpoena power with the agency or of Human Services or Department of Financial Regulation as appropriate to the agency's or DFR's work, so they don't have to go through a duplicative process. All right, and then I think finally the act directs the agency to facilitate, oh no, we're not done yet, second to last slide, to facilitate healthcare provider response to the urgent financial pressures that are facing the healthcare system and identify opportunities to increase efficiency, improve quality, reduce prescription drug spending, and increase access to essential services while reducing hospital spending by not less than 2.5% for hospital fiscal year 2026, which is the one we're in right now. It required the agency to report monthly on the proposed reductions it had approved by July 1st of 2025, and there's a report I linked to, and then to provide monthly updates that would be due from monthly from October 1st, 2025 through September 30th, 2026. So basically during hospital fiscal year 2026, AHS has a lot of those on its website, so I just put it there, but they're also on the legislative website. It also directed the Agency of Human Services to identify specific outcome measures for meeting the healthcare system transformation goals from Act 167 of 2022. So for new folks, we talk a lot about Act 167. That's Act 167, and we'll probably do a reminder of some sort on that. And report those measures and related information monthly from August 1st of 2025 through January 1st of 2027. And you can see, again, the AHS website for reports. It also appropriated $2 million to the Agency of Human Services to provide incentive grants to hospitals to encourage them to engage in transformation work. And it required the agency to report by December 1st on the amounts that had been obligated or dispersed as of November 15th. That report has also been submitted. A couple of other reports. The act required DFR to provide a plan by November 1st for preserving the sustainability of domestic health insurers, again, Blue Cross Blue Shield of Vermont. That report has come in. A lot of these reports came into the Health Reform Oversight Committee and sometimes the Joint Fiscal Committee as well. And it directed the Agency of Human Services to report by December 1st on opportunities to retain useful capabilities developed by or on behalf of the ACO and funded with public dollars. So there was some thought that there might be some resources that we wouldn't want to lose when OneCare wound down at the end of 2025. And that report is available as well. All right, this is the last slide on this. And then afterward, I have no link to all of Nolan's fiscal notes for acts that had fiscal notes. So the act requires some reporting, requires the Green Mountain Care Board to report on its implementation of this Act 68 by February 15th of this year. It also requires starting next year that the Green Mountain Care Board's annual report include updates on reference-based pricing and global hospital budgets. The act requires the Agency of Human Services to provide an annual update by February 15th on the status of the statewide healthcare delivery strategic plan, the activities of the Healthcare Delivery Advisory Committee, and other initiatives it's working on. The act created 3 new positions at the Green Mountain Care Board in fiscal year 2026, our current fiscal year, 2 related to reference-based pricing and 1 devoted to operations, procurement, and contracting. In addition to the $2 million to the Agency of Human Services for the incentive grants, the act also appropriated an additional $2.2 million to the agency for the transformation work, creation of the statewide healthcare delivery strategic plan, and its development of alternative payment models. And finally, the act appropriated $1,212,500 to the Green Mountain Care Board for its 3 new positions, contracts related to its work, and standardizing, this is a small piece in the act, standardizing electronic hospital budget data submission so that the board can more easily compare expenses across hospitals. And if you would like fiscal notes for any of those, Nolan wrote them, I just linked to them. And that's it.
And that's amazing.
Yeah.
Yeah.
Just a few things.
That's amazing. Other than the one, we barely saw Katie at all last.
I know. It's because you saw a lot of me. I was barely in service.
Tougher.
What's in my mind, and it may be wrong, did we not talk about incentivizing the nurses, something about supporting the workforce?
Hospital violence.
Hmm?
Hospital violence.
No, it was providing
I'm
incentives.
thinking it might have been, that might have been something in the budget. In the budget?
Okay, so we did do it
I
then.
don't know. I'd have to look at what it
Oh,
was.
okay, I think- All right.
There was,
In the budget for a minute.
when we were, if I recall, we were doing our budget priorities and there was extending around something with nursing.
Yeah.
I have to be honest with you, I'm not sure.
There's not much.
So,
Yeah, I'm not sure it made it through either. I'm not sure it made it through. There's only 2 mentions of nurses in the budget, and they have to do with reducing reliance on travel nurses,
also important.
which in the skilled nursing facility context, so I don't think it's, I don't think it's.
It's something to do with building that workforce to try to reduce the cost of all the traveling nurses and all that stuff.
There is some of that in this, but again, what actually passed in the budget was specifically in the context of the Department of Disabilities, Aging and Independent Living as part of its budget presentation this year to the Appropriations Committee's reporting on grants to skilled nursing facilities made through an earlier budget appropriation. And, looking at the impacts of the grants, including whether they reduced reliance on travel nurses and increased workforce retention and expansion.
Yeah. Thanks.
Maybe if anybody is following this or watching this. and
Yeah, anybody
follow.
because sometimes there's money sort of, built into the agency's budgets that fund initiatives that we don't specifically call out in here. So it's possible there's stuff you can ask about when you hear from the agencies during budget adjustment too.
Did you want to weigh in? Do you want to introduce yourself? Since it's first?
I missed the beginning, and I wasn't sure if you went around. Hi, Diane Lanford, Green Mountain Care Board. Thank you. Great start of this session. One thing I don't know this for sure, but Representative Mitford, the money in ARPA, the ARPA money that's still out there, there was an update at the December 16th and 17th when House Appropriations met from Doug Farnham on where and what's left of the ARPA money. And there's something sparkling in me, and I don't want to dare say it, I'd love to know how much, but I thought there was something in there around workforce development or nursing, but so that might be another place that we all think about. That dollars are still active.
Yeah.
They're still working.
Because that's a big deal.
It is a big deal.
Good.
Thanks for following all of that. I know you can't get away from appropriations.
It's always helpful.
Karen, did you?
Yeah, I just had a couple of questions. I don't need to take time now if it's just if it's a big answer. There's a mention of critical care hospitals and some distinction made about those. And I didn't understand it. And I don't want to take a lot of time, but I'm curious about that. And then also about the development of the reference-based pricing going forward, not just the drugs, but the other things, and how that actually gets implemented. And those are my 2 questions.
Why don't we, in your 101, you'll go over what hospital types there are, correct?
I just said there are 40 hospitals that don't get into the weeds.
Okay,
about that.
maybe we'll get.
So it's a federal designation as critical access hospitals and
it impacts the control one can have over those hospitals or?
not necessarily. I think they're often smaller hospitals. They're, sort of the only care available in the area. And so I think sometimes there is concern about doing things and they may have smaller margins and they're maybe concerned about doing things that affect their financial health in ways that are maybe less of a consideration for areas that are more urban.
They get paid different
They get paid
reimbursement
different.
rates from the
There's
feds.
different types of federal designations for hospitals and they all sort of have different payment mechanisms.
And that's good, that's generally.
And we had exempted from one of the bills that she had up there. We had
Yeah, I think there's a
exempted
couple,
critical
yeah, I think there's a
access
couple of places you've carved out critical access hospital. And the other question was about reference-based pricing and sort of who owns it going forward. Green Mountain, it's all in the Green Mountain Care Board, so it's a pretty broad provision. It arguably could have existed or existed harmoniously with their rate-setting authority that they had not exercised. But it was directing them to start implementing reference-based pricing, starting with the hospitals, but looking at potentially going more broadly to other types of providers and provider settings and services.
And we're gonna get an update from
Yes.
Green Mountain Care Board very, very soon.
Yeah.
On how that's going. All right. Thanks, Jen.
Sure.
Thanks for all your work last year and.
Well, I look
And
forward to
you're
working more
absolutely
now.
right. I totally forgot about those things.
Right, I know, I didn't.
I have a confession. We were at a meeting the other day and Jen was there and I said something about, well, with the markets merged. And Jen looks at me, she's like, you unmerged them last year permanently. I'm like, no recollection of
We
that.
sunset the sunset or something like that. It was a
They had
sunset.
that when we just.
We just got rid of the sunset or.
Yeah.
something.
There was no sense,
Yeah.
we just,
All right,
just unmerged.
no one. You wanna come on up?
Talk about what?
Oh, I don't know. You're on the agenda.
Miracle Hair.
Anything you want.
I guess you don't need to, if you don't want to. I thought we had you on the agenda for. What were we talking about? Economic changes?
We talk about tomorrow,
Yeah, we're gonna talk about it tomorrow.
but today I think it was just there, but I don't.
Okay.
Anything specific.
All right. Well, we can take a long break or we can take a break until, I don't know, is AHS, people at AHS gonna be joining us remotely or?
Joel's gonna be in person, but the rest are over Zoom.
All right, so they're scheduled at 3, but maybe if they're able to come a little earlier, then, and they happen to be here, then we can start earlier. So be checking the committee room at 2:50, maybe? All right, we can go off of live.
So if I can just say really quick, the new legislation.
We're still live.
That's the key. So.
We can go off of live.
Oh, sorry.
Just to. Oh, okay. How do you know?
Run.
think I'm gonna have to take notes of it.
Okay, now everybody can hear me. Oh, there you go. Wait, you had it for a second. Okay,
We're just gonna go to sec.
there we go. Okay, so we're back, and we're still live.
You'll be able to see them once they turn my cameras on.
Okay.
They are there.
Okay. So we're gonna get started. And we have with us, the new, what is your title now? Have you learned it yet?
Good morning.
You introduce yourself.
Okay,
Yeah.
sure. Good morning. I'm Jill Mazza Olson. I am the Medicaid and Health Systems Director. So I've been in the role since about October. Thank you, Representative McFawn. And I know many of you. For the past about 25 years, have been working in healthcare policy, but on the provider advocacy side. So this is a big change for me. I know a lot, but I don't know a lot. And so I'm really excited to be here today. I do have subject matter experts who are joining us today. And today I'm going to be more in your kind of Wizard of Oz mode, sitting in the chair while they do most of the talking. Tomorrow I'll talk about rural health transformation and you'll hear more from me.
Karen, do you want to introduce yourself? Because I think everybody here would know everyone else, but.
I know because I was on Addison County Home Health and Hospice. She was our fearless advocate when I was in that position. So I know her.
Yes, it's good to see you here.
That's awesome.
Yeah.
And I see we have Ashley and Addie now. Hi. Hi, welcome, guys. All right.
And I think it's Ashley who's running the slides. Is that our plan? Okay. Great. We do have a series of slides. And shall I let them introduce themselves?
Yeah. And also just to let you know, I've asked them to come in because I don't know if you remember last year, we had the joint hearing with Human Services. This was before HR1 passed. And if you recall that there was so much stuff, and I'll never forget, Ashley, your spreadsheet. And it was just one horror after the next. So I figured we should have an update from, what actually came to fruition out of all of that. So,
Okay.
I'm gonna get copies.
it's on our web. It's on our web.
On the website.
Is it?
Our website.
I'm checking.
Yep.
Oh, look, it's a Tuesday.
Okay, go ahead. I'm sorry.
So can I let Addie and Ashley introduce themselves?
Absolutely.
Okay, great. Ashley, do you want to introduce yourself? Oh, she just shared her slides and then I said introduce yourself, but that's okay. She's going to do all the talking.
Hi, yes. I'm Ashley Berliner. I'm the Director of Medicaid Policy for the Agency of Human Services. Good to see you all.
And Addie?
Hi, everyone. Addie Stromolo. I'm the Deputy Commissioner at the Department of Vermont Health Access, or DVA.
So these are two of the most competent people I have ever met. And really the right people, I think, to give you the overview of what I think this committee needs to know and sort of the primary changes that happened in HR1, which passed in July.
I just want to be clear. You and Ashley, you're actually housed in the agency. You're in the central office.
I am in central office, exactly. I work directly, just if this is helpful to you, I work directly for the secretary. So I report to the secretary and sit in the secretary's office. Ashley's team, the Medicaid policy team, is actually also in the AHS office. So that's separate from DVA, where so Addie works for DVA. So that there is some separation there, which is sometimes actually useful and helpful within our Medicaid world. So Addie's in charge of Medicaid policy. Ashley's in charge of Medicaid policy. Addie's in charge of our enrollment. And I also have responsibility for healthcare reform. So Ashley Berliner reports directly to me, and the Director of Healthcare Reform, which is actually a vacant position right now with an interim leader, reports directly to me. The idea is to try to kind of make sense of all of this across the agency, but it is certainly a large portfolio, which is why I rely on subject matter experts on when there's this much detail.
Sorry,
Just
Brian.
to clarify before you begin.
Sure.
I was very confused at first by HR1 because it's a rules resolution in our house. But then I realized, is that HR1 in Congress?
Yes.
Ugly
Okay.
good, ugly good.
Right, but it's so like.
That's what
maybe
we
just-
call it.
Yeah, so just maybe clarifying, like,
Reconciliation bill.
it's the federal HR one. In
Federal
case,
HR one,
when
yeah.
I looked up H1 and HR, I couldn't find it, and then I was like, oh, this is federal.
Yes.
And maybe everyone would eventually figure that out, but I just thought we should clarify. that.
Thank you. I appreciate that. This is how we talk about it internally, so it's sometimes hard to remember what it sounds like externally. So thank you. I appreciate that. Okay, so I'm gonna just sort of give a very quick overview of what we're gonna talk about, and then I'm gonna essentially turn it over to the team. So we're really looking at the major provisions that impact either Medicaid or healthcare as a whole. So we're gonna talk about Planned Parenthood, provider taxes, and I'm not sure, Ashley heard you say this, Madam Chair, but it sounds like the committee is gonna get a full primer on what provider taxes are, so we don't have to go too deep. But there are impacts to provider taxes we'll want to talk about. It's essentially a revenue impact. State directed payments, cost sharing, and then eligibility. And there are multiple elements under that. And we'll switch to Addie at that point, the deputy commissioner at that point. Okay. All right. I'm going to turn it over now to Ashley Berliner.
Thank you. So the very first thing that was in effect when HR1 or the big beautiful bill passed on July 4th of 2025 was a prohibition of federal Medicaid funding for Planned Parenthood or Planned Parenthood-like entities. This went into effect for 1 year. Can you guys hear me?
There's a phone ringing. Yeah.
Okay.
Not mine.
Sorry about that, Ashley.
No problem. The federal impact for the state of Vermont is about $1.1 million gross for this 1 year, or about $600,000 in federal financial participation. We have decided to backfill that lost federal revenue with general fund for this 1 year period. You might hear in the news, there have been many lawsuits related to this ban on Planned Parenthood funding. There have been injunctions that have been overturned and then reestablished and then overturned again. So we are just holding steady at general fund. When the final decisions shake out, ultimately likely in the Supreme Court, then we will settle up if federal funding can in fact be used, and if not, we'll be all set with our general fund backfill. So we're just waiting on final court decision there.
And just to be clear, so 1.1 million is the total that loss of that, and the state out of general fund is having to make up the 600,000, which would have been matching federal funds?
That's right.
Okay. Thanks.
So moving on to provider taxes, this is a provision that goes into effect immediately in terms of states cannot create new provider taxes after the effective date of HR1. And then in November of 2027, for states that have existing provider taxes, you are required to reduce those provider taxes by 0.5 percentage point per year for 5 years until you get down to 3.5% in 2032. So this is kind of a slow burn impact, where in the first year, if we reduce our provider tax from 6% down to 5.5%, it's a loss of $18 million in revenue, general fund revenue per year. Cumulatively over 5 years, that adds up to a loss of $87 million in today's dollars for general fund revenue. So you can see that this has the potential to be a really significant financial impact for Vermont. We're looking at this from a lot of different angles and are grateful that the deadline for this is not until the end of next year.
So this is not a this year budget problem, it's a next year budget problem.
But we're thinking $87 million. We'll get to $87 million by the fifth year, and it'll be essentially the equivalent or whatever that time period, $87 million is actually real. And that will be each and every single year.
Yes.
$87 million per year that we are foregoing total.
that's what the reduction would be if we do in fact have to reduce our provider taxes down to that 3.5%. And we're looking at this from a lot of different angles and working with tax and Department of Financial Regulation on it as well. So definitely an ongoing conversation, but that is how it would shake out financially by 2032.
Okay,
I have a visual on this that'll be helpful.
okay, great.
I'll save my question for that.
All right, okay, super.
I think you're gonna answer my question.
Okay.
Thank you, sorry.
And I'm moving right along on these, so please, I'm glad you're stepping in with questions. Addie's gonna have most of the real meat of this bill, but wanted to make sure we had a chance to talk about some of the other provisions that impact Vermont. So this one has a direct impact for you all in your seats as state legislators. We have something, it's a term of art in Medicaid called a state directed payment. And it's essentially where states, or in your case, the legislature, require a plan to pay healthcare providers in a very specific way. So in Vermont, the plan is DIVA. And anytime the legislature is requiring DIVA to set Medicaid rates at a certain place and manner, that is considered a state directed payment under the provision of this bill. So what that means is that effective July 4th, 2025, state directed payments that exist today are not able to grow, and new state directed payments must be capped at 100% of Medicare fee schedule. Existing state directed payments above Medicare rates will need to be reduced by 10% per year beginning in 2028 until that state directed payment is no greater than the 100% of the Medicare payment level. So that's a lot.
Is this like, for an example, we pay primary care enhanced? Is it that we have to phase down that till it meets 100%? Because I think right now it's around 110%.
So primary care is an example where the legislature has said DIVA has to pay at 110% of Medicare rates. And that would be something that's implicated under this provision. We also have two federally known state directed payments where we actually have had to call them out as state directed payments. And that is the Blueprint for Health Community Health Team payments and patient-centered medical home payments. Those are also above Medicare rates. None of this would be impacted until 2028. So again, not a this year budget problem. This would be something that we'd be looking at next year. And we're really digging into this and exploring our options. There are ways to make sure that we have the money, that DIVA has the money to pay for these things without the legislature or AHS specifically directing them to pay it in a certain way. So we're really just like putting our thinking hats on and thinking about how we can work through this problem, and want to just raise it to this committee in particular. When you're building your budgets this year, we need to be really careful about not specifically directing DIVA to pay in a certain way. The money can be available, it can be in their budget, but to say you have to pay primary care 110% Medicare rates, or you have to pay $2.50 per patient per month for Blueprint, or you have to pay the Medicare rate for this treatment non-transport code, that's where we get into state directed payment land and need to just be really careful about the implications of this bill.
Are we worried about losing the federal match when we pay, or are we worried about the impact to providers?
I think right now we're worried about how to make sure we're in compliance and really making sure that we're doing everything that we need to do to be in compliance while still making sure that providers are getting paid the way that aligns with our values in Vermont. So there are some administrative things that we think will have flexibility to do. We don't have that all sorted out yet, and we'll certainly, be in communication as we figure out the guardrails. But that's where we are right now. I don't think that this isn't something to be alarmed about this year. It's just something to be aware of, particularly as you're setting like the budget going into the session, and just staying away from some of the language that's going to put a spotlight on some of this. And hopefully that helps a little bit.
It doesn't stop us from the legislature mandating that certain rates be raised to 100% though, does it?
It doesn't, no, the major factor here is 100% of Medicare rates and not going above that. There are some other strings attached when it is a state directed payment that we just want to make sure everyone's aware of, and we're still working through. But right, raising rates to Medicare levels is not going to be hampered by this bill.
Okay, thanks.
And just to provide a little bit of context, because it's kind of a obscure thing that got raised nationally and became a huge deal in this bill. A lot of states are using state-directed payments as a way to infuse their healthcare system with federal Medicaid dollars, or kind of artificially. That's not happening in Vermont. We just don't run our Medicaid program that way. But when you're looking at national politics, that's really what they were trying to prevent, was having a lot of states kind of artificially infuse their Medicaid rates with federal dollars at the savings of state budgets. And again, not relevant to us, but just so you have a little bit of context for where this is coming from.
Did you have a question, Karen?
I do. So if we don't use the words state directed payments, what words might we use? Are you still thinking about that? To achieve.
I think we're still thinking about how we meet the policy goals and how we can do that and be in compliance. But we are, I think, feeling as though there are paths forward, but we just need to do some more work. Yeah.
So the last piece before I hand it over to Addie to talk about eligibility is around cost sharing. And the top line here is that in October of 2028, for the new adult group or the expansion group that became eligible under the Affordable Care Act, for individuals who have incomes up to 100% of the federal poverty level, we will be required to impose cost sharing in the form of co-payments on all services, except for a specific list of exempted services like preventative care, emergency care. There are some carve-outs for categories of service. We will have flexibility to decide what those copay amounts are. There are still some federal protections, like pharmacy copays can't be above $8. There are still things in federal law that apply. But we are, in this particular one, awaiting regulatory guidance because we need a lot more information around what the federal administrators want before we can think about how we would administer this. But just something to be aware of, that our co-payments will be having to increase broadly in 2028.
I'm sorry, I keep interrupting you, but I have so many questions.
Okay.
So for expansion adults up to 100%, those are the people who are going to be required to pay co-payments. Our expansion adults go up to 138% of FPL. So are you telling me from 101 to 138, those people don't have to pay co-payments?
That is a great question. Let me get back to you.
Because that seems a little backwards.
It might be backwards. It might be above, and it might be a typo there. I can't say that with 100% confidence right this second, but let me get back to you. It's a really great point, and I'm going to assume it's a typo.
Either that or it's a really, really bad
Really bad policy. Well, there could be that.
Okay, all right,
You can
thank
go
you.
research it and I can take over.
Okay, thanks, Addie.
No, unless there are other questions for Ashley, which is fine. Okay, so as I think you all know, in my role as Deputy Commissioner at DEVA, I oversee eligibility and enrollment into both Medicaid and the Qualified Health Plan Marketplace. So our teams are kind of the entry point for people to get and then maintain healthcare coverage in our state. And this eligibility process is really one of the major levers that was used in the budget reconciliation bill, HR 1. So a lot of the near-term work is with us and with our teams. We began work right on passage this summer, including some small pieces that had to happen for open enrollment for this year. But right now we're focused on 3 major provisions requiring implementation in late 2026 and then January 1st of 2027. And then there's a 4th provision for 2028. So we can go to the next slide. The first major provision is, are you guys seeing the next slide or?
No, we're still on the 4 work streams slide. There.
Thank you. So the first major provision are changes to healthcare eligibility based on immigration status. These changes apply across Medicaid. They're not limited to certain eligibility groups and are effective for October 1st of 2026. And then the commensurate change happens for the marketplace as of January 1st of 2027. So this effectively blocks eligibility for asylees, refugees, and other non-citizens who currently are eligible for coverage. This one is a little bit hard for us to quantify because people do not have to provide this level of detail in their application process as it relates to their immigration status when coming through the door into Medicaid. So a major area of focus for us is just identifying the scale of the impact. We think it's in the hundreds, but so that we will be able to effectively outreach them ahead of the change and ahead of actually making the adjustment to our eligibility process for next fall.
Do we have any sense yet? I know that you said you're having difficulty identifying. Do we have a sense yet how many of these hundreds might be under or might be children? Because I mean, I'm concerned because that population will automatically qualify for IHIP, and that's all state dollars.
The short answer to your question is no, I don't know the breakdown by age. And we will work hard to get more information about this to you all because I think it will be a consideration because, yeah, as you said, probably a small subset may become eligible for IHIP and the rest will not have access to, full healthcare coverage in our state anymore.
Can you remind us of that acronym?
IHIP is,
Immigrant Health Insurance Program.
Thank you. First bill, I can't believe I can't remember.
That's okay.
Essentially what it is that if you're a child or a pregnant person and you're eligible for, it's state only dollars. If you have a immigration status that doesn't allow you to qualify for Medicaid. So now that this population won't qualify for Medicaid, they would roll into that if they're children or pregnant people. Thanks, we can go on.
Okay, sounds good. We can go to the next slide. So the next major provision is we refer to as 6-month renewals. Renewals or redeterminations are those mandated rechecks of eligibility in order to maintain coverage. This change, unlike the prior one, applies to a subset, which is that Medicaid expansion population that Ashley described. The expansion population are non-disabled adults eligible for Medicaid based on income, up to 138% of the federal poverty limit. And we refer to this generally as the new adult population. So this change is effective also for January 1st of 2027, and it increases the required redetermination frequency from every 12 months to every 6 months. It's a really significant change, as everyone will remember from our experience unwinding or restarting redeterminations. This process can be onerous for people, and having to do it twice a year instead of the annual cadence will be a big change. There are currently about 55,000 new adults in our system that will be subject to this new requirement.
55,000. Addie, you don't have to give like, just sort of on a high level. I don't think we've ever, all the times we talk about redeterminations, what exactly does that involve? Like, what is the onerous process like? I honestly don't know. I mean, is it applications? What kind of income proof? How do you do a redetermination?
Yeah, kind of all of the above. And I you know, our job is to make it less onerous, but I don't want to kind of hide the ball on that. So the process is we'll outreach, everyone's assigned a redetermination date based on when they originally came into coverage. They get outreach through notices in different modalities starting a month or so ahead of time. And then we do our best to check the information that we have on file against electronic data sources. And if we can verify all that information using those data sources, we then send a notice that says, okay, you're good for another, in the new case, it will be 6 months. Currently, it's a year. If we can't check it with data sources, then we basically ask the customer to validate all their information again using paperwork. They can submit it through different modalities, but they have to validate all of the eligibility factors like income. And then we make a determination about whether they still meet the criteria, get another notice that says whether or not they're good. And that back and forth with the paperwork can take a lot of time.
What sort of human resources does it take right now to do 12 months? And what would you anticipate increased need?
Overall, these changes that I'm going through here are going to reflect about a 30% increase in our workload. We will talk more about the resource needs when we start talking about the budget, but it is definitely a big increase.
Thank you. Oh, Brian has a question.
I feel bad because I just zoned out the last few sentences. So if this was just answered, forgive me. I just got an email that distracted me. But my question is, how much does it cost the state to do this extra work that we're not doing now? Do we know? Or is that something covered by Medicaid? You know, like the cost of the renewals is extra labor that we're not doing now. Like, is that covered by the feds, or do we have to cover those renewals to get the federal money? Like, is that going to cost us more? Besides the stress and emotional labor, like in terms of just the actual financial expense. If you don't know, it's okay.
No, I know the answer is definitely yes. The specifics of how much are, again, something that we'll talk about in our budget recommendation. But there are various administrative costs, IT, operational, staffing, as I just mentioned, that are absolutely a shift to the states to do these processes, to make the process slightly more strict for people to maintain coverage.
And I think, Addie, I heard you say a 30% increase in workload,
Thank you.
not cost, but workload.
Yeah.
Do we currently receive a federal match on the expense of administering state Medicaid program? Do we?
Yes.
We do.
Yeah.
Will that continue?
Yes. Yeah, the administrative match is not changing.
Okay.
We get an enhanced
Just
match for things like IT.
Because Leslie,
Can you say what that match is based on?
I might defer to Ashley on that. Is it just 50-50?
Yeah, it's a 50-50 match for Medicaid administrative costs.
So
But if our
the
costs
shared-
go up, if our administrative costs go up by 30%, then does that mean the match goes up 30% or some percent?
They'll pay 50% of the increased cost.
So they will pay more anyway.
Yes. Same rate. Okay, so I think we can move on to the final piece for this year, which is Medicaid work requirements, or these are being referred to as community engagement requirements. This also applies to the Medicaid expansion population that we just described and is also effective for January 1st of 2027. This is a brand new requirement, and it asks members to demonstrate that they are either working, engaging in community service or education, minimum of 80 hours per month, as a condition of maintaining their Medicaid eligibility. There are a number of exceptions and accepted populations built into the legislation, like pregnant individuals, medically frail individuals, those with children under 14. So this one is also a little bit of a moving target in terms of the impact, but if you take the exceptions into account, we think this change will impact about 30,000 members just in terms of needing to provide additional verification around work requirements in order to maintain eligibility. It's a big change, and then coupled with the enhanced frequency of the renewals for the same population, this is kind of the essence of the increased work that we'll be facing and the increased requirements for Vermonters coming up next year.
If you have to do this every 6 months, how do you prove that for each of those 6 months, you've been working for 80 hours? And
there's, sorry, I didn't mean to cut you off.
Well, no, and I'm also thinking about, I'm thinking about, you know, ways that people actually end up having to apply for Medicaid. And isn't a lot of our sort of new adult population that's on Medicaid, aren't they people who have recently been impacted by loss of a job? Or how do you, I mean,
I probably can't speak
anecdotally, I'm thinking about friends who have become unemployed, and when they become unemployed, they lose their insurance, and then they qualify for Medicaid, and they're only on it for, you know, until they're able to find it. How do you have a work requirement for somebody who just lost a job?
Yeah, I mean, it's absolutely a kind of philosophical change in the program. I'm trying to remember, your original question was not specific to the loss of employment. Oh, how do you prove it every 6 months? So we're working through that now. We have some flexibility, and we think what it's going to be is demonstrating that you meet the standard for 1 month within that coverage period prior to your renewal. And we're working really hard to add data sources to our system to hopefully, you know, reduce the paperwork burden of having to demonstrate that. But that's kind of the bread and butter of this implementation, is figuring out if there is data that can support Vermonters in maintaining coverage, and how we can get it into our system so that we can do that.
Robert, did you have a question?
Yeah, I do. You keep using the term Vermonters. What does that mean?
I'm just using it to mean people who reside in the state, but then there are categories of eligibility, including this expansion population that's based on their income level. So those are the specific Vermonters that would be impacted by this change.
Thank you.
Of course.
We can go on.
Okay. The next slide touches on the fourth work stream, which is actually in the marketplace space, qualified health plan renewals. Yep. So this is a really significant change, but one that we actually haven't started working on yet because it doesn't come into effect until the 2028 plan year. So open enrollment will take place in the fall of 2027. This is a new requirement that instead of automatically renewing people into qualified health plan coverage, which is something that we do now and that happens kind of everywhere in the insurance world, there will be a requirement to validate people's eligibility every year. And we're still working on what that looks like, but it is definitely a sea change in terms of what the process of open enrollment will look like. I guess the good news is that we do think that CMS will issue implementing regulations around this in the next year. And so it may be that they can find a way to do it in a way that doesn't come out to be as onerous as it appears on paper. But this is something that we have on our docket to start as the next phase of the project once we finish the 3 that I just went through.
What sort of information would somebody even have to verify on their application that would mean that they can't qualify for something that pretty much anyone qualifies for because they're purchasing insurance?
Thank you. Yeah, I should have clarified that. It's really focused on eligibility for the premium assistance. As you know, it's a large percentage of our marketplace population qualify, even with the expiration of the enhanced subsidies. So if someone just wanted to come in and not even apply for assistance and just buy a full cost qualified health plan, they wouldn't have to go through this new process. But most people go through the steps of providing information to see if they can, get some of the tax credit. And so that's the typical information like household size, income, and then of course, citizenship, Vermont residency, social security number.
Isn't your income though all just trued up with your next year's tax return?
It is, but this policy is to not allow people to take that tax credit in advance until they have documented their eligibility.
Got it.
There's no more 5-year agreement to automatic renewal then on these applications?
Yeah, that'll be interesting to see what they do with that 5-year requirement for accessing the IRS data. It may be that they keep it in place. They just require that to happen ahead of enrollment rather than as part of the enrollment process.
Brian has another question. Go ahead.
Yeah, and we can come back to this another day because this is just the beginning, but do we have to do all this? Like, can we just say, never mind, we don't want your money anymore. We're going to do our own healthcare system. Like, we don't want to participate in health exchanges and renewals and all that, or are we like forced by federal law to engage in this?
I don't know if Phil wants to answer that, but I think it's a matter of money. We would be seriously damaging the state budget if we left those federal dollars behind.
Right.
Yeah, I think what's important to remember is there are still premium subsidies, right, available to people that we care about. Even without the expanded subsidies, there are still subsidies that we're receiving. So to just say we don't want to do this, I think would have a pretty big impact on the federal budget federal dollars that we're bringing to the state.
So would it be correct to say that there's a lot of benefits associated with these extra barriers, and if we didn't jump through these hoops, we would lose a lot?
Well, right. You're talking about all of them, all of these provisions?
Well, I guess this one particularly triggered me, but I just feels like they're throwing up all this bureaucracy. They talk about efficiency and improving the efficiency of government, and then they're asking you to do all this extra stuff that's going to be inefficient. So it's just confusing to me.
I think we can leave that. I'm not going to editorialize on that, but
I just got just a question in general about the exchange. What is it? I really don't know because I don't know the history of it. What is the advantage for Vermont having its own statewide exchange? What is the difference between if we just were on the federal, if Vermonters just were on the federal exchange?
Yeah, I'm happy to spend a lot of time on that. The short answer is that we wouldn't be able to have our state subsidies. We wouldn't be able to have a Vermont specific call center, for example. We wouldn't, it would just become, we would go into the kind of federal machine and have a lot less control over what we're providing to our state.
But we wouldn't be administering it.
Right, the website would be a federal website instead of a state website.
No, I'm not threatening to do that, don't worry. I just wondered what the. Just in time for everybody. I don't think I ever really knew what the advantage is to having a statewide versus, half the states seem to be on the federal, half have their own. Anyways, let's move on.
No, happy to have that conversation though, maybe when we're talking about the affordability challenges in the marketplace right now. But yeah, on this topic, I think we're toward the end. I had one more slide just kind of describing this is just what we are doing this year, all of these various implementations that I described. So it's kind of it's a big IT project, but then we're really importantly working to try to mitigate resulting coverage loss among eligible Vermonters. And as I mentioned before, focused on things like IT updates, data sharing to do as much as we can without requiring paperwork from members. It's very much underway. We are partnering with entities throughout state government, and that's going smoothly, although it's not a very long runway. Once the systems are updated, as I mentioned before, we're expecting a very large uptick in our enrollment transactions that we process during 2027. So increased redeterminations, verifications, reinstatements, that we think is about a 30% increase to our workload. And then I also got at this a little bit. There's a little bit of an analogy here to the restart of the Medicaid redeterminations that we went through after the years-long public health emergency pause. And we did learn a lot from that experience and hope to leverage it in this implementation. Things like system updates to support those automatic redeterminations, member communications through different modalities, other outreach and partnership to make sure that people have access to resources to retain their coverage. So just wanted it to be very clear that as we enter this work, we are focused on keeping people on the rolls. That is our goal.
Oh.
And then finally,
No, I wanted to, just because it wasn't addressed in your slides, and I don't know if it actually happened or if I'm imagining, because there's so many things that we were trying to keep track of. Are you going to be able to backdate anymore? Or did they put in there that you were unable to backdate? I know at a certain point, I had thought that was in there, that you couldn't backdate Medicaid.
It wasn't a blanket. So there is a piece about limiting the availability of retroactive coverage. That's right. So instead of a standard 3-month retroactive availability, it is reduced to 1 for certain populations. And that is a piece that made it in. It was not, I think maybe at one point it was more of a blanket. There can never be any retro. And that is not what passed.
And I just want to be clear, because what that would mean is that if somebody missed in this, onerous redetermination process, if it was over a month, they then would not be eligible because they're not during open enrollment. They wouldn't be eligible until next year's open enrollment, because they wouldn't have a qualifying
well,
event.
For Medicaid, we don't have the open enrollment period,
Oh,
so
that's good.
it can happen at any point during the year. And this gets a bit technical, but there's there's a different policy around when someone is eligible for reinstatement. So if they were on coverage and they drop it because they weren't able to send us the paperwork in time, they still have 90 days to send the paperwork in and then get their coverage reinstated. So there's that availability still exists, but you're right that there is a reduction in the availability of retroactive coverage, which is a slightly different scenario where someone fully is disenrolled and then has to restart their application process.
Okay, thanks. Sorry to derail you there.
No, thank you. Go ahead. We just have one more slide, which is a visual depiction of the IT and project work that we are doing over the course of this year and how it interacts with things like open enrollment that dictate the schedule, the typical schedule. So happy to take any other questions you may have.
I had one, but Tupper and then Lori.
Could I go back to the previous slide? I'm confused about, the last sentence there. The note. Can you?
Sure. Yeah,
can
thank you for.
Explain what that means by, an example maybe?
Yes. So when we restarted Medicaid redeterminations, one of the most important pieces is that when someone came back and realized that they were no longer eligible for Medicaid, we were able to transition them to qualified health plan coverage. So say their income had increased over the course of the pandemic, they were able to transition to another program. In the case of work requirements, if a Medicaid enrollee can't meet their eligibility for Medicaid because they don't meet the work standards, they can also not go to the marketplace. That's a prohibition that's built into the rule, the law, rather.
Lori?
Addie, I apologize. I had to step out to deal with a health insurance issue, so I missed some of this.
She'll be calling you later.
And no, I'm so I'm sorry if this question was asked, but so is there any pending federal litigation on any of this that could affect not having to do any portion of it in the future?
That's a good question. Not to my knowledge, not on these pieces.
Thanks.
I think it's possible that we've seen some litigation around the implementing regulations coming from CMS, and it's possible, well, for one, it's possible that's a reason why they might be delayed in putting them out. But if they do, that might be a moment when we would see more action in the courts.
Okay, thank you.
Mm-hmm.
Other questions? I had just one, which is sort of unrelated to HR1, but I wanted to ask either Addie or Ashley or Jill. While I've got you here, I distinctly remember the joint hearing that we had with Human Services and Ashley going through her spreadsheet of possible things. And I just remember getting to the 1115 waiver. And aren't we in negotiations right now for the renewal of and I'm wondering how that's going.
She'll take that.
I think I remember your face getting really white when
it might be getting really white next year. So we are spending this year, 2026, drafting our application. And then we will spend 2027 negotiating with CMS. So our waiver expires at the end of 2027, and we have to submit it by December 31st of this year, and then spend that full year really negotiating the terms. So next year is going to be the really insightful point in time where we figure out what our waiver looks like going forward.
Have we seen any experiences with other states in this past year?
We've seen waivers get renewed. There is nothing like our waiver out there. And I think what I said last year and what still is true today is our investments are at serious risk. Like that is the piece that we are really on an island with in terms of there's no other precedents in the country for those 1115 investments. And so that feels like it's going to be a really hard fight. I think other pieces of our waiver, there's a lot more reason to be optimistic, but we haven't seen any like one for ones and we don't expect to. New York and Massachusetts will negotiate ahead of us. So we'll get about a 6-month lead time on how their negotiations are doing, but hoping that we can kind of hide behind them and not draw too much attention to ourselves while they're dealing with much bigger fish.
One of the items at risk is the Vermont premium assistance. I think that's of interest to this committee as our state subsidy for the marketplace.
And how much is that a year? Do we know? Like, right, I know it's been different because we've had the enhanced, but do we have any idea how much?
I know you've asked me this before and I still don't have the number off the top of my head. Do you, Ashley? We might need to wait till the budget presentation too, because like you said, it's different.
Yeah.
It's like 5 to 6 million, that range.
Okay, and that's what it currently is.
With the current reduction because of the enhanced subsidies. That's the
Exactly.
amount.
It will go up.
It'll go up.
We're gonna have time with Nolan to really look at the numbers tomorrow, right?
I'm in front of tax tomorrow.
Oh, that's just one element of the numbers. Okay.
It's a big one.
Dive into
Yeah.
what our provider taxes, make sure we all understand that. Thanks. Thanks. I really appreciate you coming in to give us this outlook. Let's just say outlook.
Opening day outlook.
Yes, here we are. Thank you.
And thank you for all you guys are doing, because I know that this has just been, this is a lot. It's a lot. So really appreciate it. All right. I think we're all